Hello, everybody. This is Dr. Radialis again. I have a companion in the back, so just disregard her. It's another day in this beautiful universe of ours. And I always like to talk about a particular subject that we encounter through the week. And I'm going to talk about trigger shots today because it was an area of discussion earlier this week with some patients. So essentially, there's two medications that are used for doing the trigger. What does that mean? That means provoking the ovulation when the follicles are ready and big enough, okay? So two medications is Lupron or Luprolide and ACG. A lot of people get confused about because we use low dose ACG through the stimulation and then high dose ACG to mimic the LH surge that happens naturally during a ovulatory cycle. And it is the same medicine, it's just used slightly different. And then the Lupron or Luprolide can be used at different ways as well. But when done, because the Lupron is a GnRH agonist, so it's at the level of the hypothalamus. It is a stimulant given short doses or short term, while when it's given prolonged, it actually suppresses, and that's where it kind of it can be used either way. It could be used as a suppressant and it can be used as a stimulant. So it depends on your protocol and what are we trying to accomplish. Lupron is used for endometriosis and fibroids in the GYN world as well. All right. So what to choose and why? And I believe that knowledge is power. So I wanted to discuss this with you. In general, we try to trigger with Lupron and ACG. Lupron is a safer trigger, and there's some evidence showing that it helps with the maturation of the egg, so actually having more live embryos, okay? It is a safer trigger, so somebody that is on the younger side, so 35 and below, they're responding very well to their stimulation. They have a whole bunch of eggs, a pretty substantial amount of estrogen. So, 2,500, 3,000 of estrogen. Then we might want to be a little bit more conservative to avoid a possible hyperstimulation syndrome, okay? Above 35, I am definitely a little bit more aggressive. Past 40, you really want to use a dual trigger with higher doses of ACG, because then what happens is you really need to push a little harder with low AMH and so low reserve patients and older patients. You stim gentler, but you actually have to trigger harder. So it's that little game that happens, and I know that for some of you that could be a question. Now with the Lupron trigger, it's 2 shots 12 hours apart. They're different protocols, but that's the one that we follow because it has a better response, okay? In terms of possible complications with the trigger, like I just briefly mentioned, if you're on the younger side, 35 and under, very good response, or you have sensitive PCOS. There's 2 groups of PCOS, the ones that are very sensitive, which is probably 80% of the polycystic ovarian syndrome patients. And then that group and the younger crowd, you want to be a lot more gentle with the trigger, because you could push the body on the hyperstimulation, which is kind of swelling. Just imagine very, very high doses of estrogen and just swelling everywhere. If it's minor, meaning a little bit of bloating, you could have a little bit of leg swelling. And then if it's major, then you're talking about water in the lungs, which is it's the complication from hyperstimulation that we kind of get a little nervous. You can have water in your belly or ascites. So, but believe it or not, most cases of hyperstimulation are mild and can be monitored outpatient without any problems. If there's any concern of the possibility of that, you can address it. You don't want to do a transfer, so no fresh if there's any chances of that happening. And you want to be aggressive with potential diuretics and carbergolene, okay? But we don't see it very often, even though, a lot of people are scared of it. And so sometimes we might need to push a little harder to get more eggs, even though, that might be a risk for a mild hyperstimulation. All right, so let's just look through some of your questions. What is the chances of going through menopause at 26? It's very low. I have had that happen, especially for ladies that have other autoimmune disorders. Having an autoimmune condition will predispose you against another autoimmune condition. So somebody with, for example, Graves' disease, Hashimoto's, rheumatoid arthritis, lupus, will have a higher tendency of autoimmunity against the ovaries and then premature menopause. I have a girl, or like 27, 28, that will be using donor eggs. The spotting count as day one, I've been spotting all day and I've been getting conflicted info. Day one is usually when you actually see red. It's going to depend on how your flow is. If you have a very light period, that might be your day one. It is not that important. It's not as important as most gynecologists make it seem. Okay, you can even start treatment just on that spotting day. So in general, we tell people once you have, robust flow, then count that as day one. But if you have a light flow in general, just count your spotting as day one. Okay. I keep sending messages, but no reply on my portal. Why wasn't I treated for ovarian hyperstimulation before my transfer? This resulted in a failure. Did you develop any signs of hyperstimulation syndrome? Did you try to do a fresh after having a lot of eggs during a retrieval? I'm sorry if there was no reply. Some of the symptoms of hyperstimulation, especially right after retrieval, it's just feeling really bloated, a little bit more than usual. So if that's the case, or if the retrieval was very extensive, you had 25, 30 eggs, you really don't want to go into a transfer. Okay. I started birth control at 28. My cycle is starting. Do I need to make an appointment or wait until the birth control is over? If you're still taking the birth control pills, the active forms, you can call and, get ready. Usually after the last active pill, meaning 21 days of that birth control, you can just go ahead and get a baseline. You don't have to kind of wait for the period after birth control pills. What protocol do you recommend for an AMH of less than 0.1? An AMH of less than 0.1, it's a challenge. We're talking about getting 1 to 2 eggs per cycle. Very low dose protocol for very low AMH. And I would definitely do priming for 1 to 3 months of with human growth hormone, LDN, keto diet, female endocrine pack, ovarian bloom. Ovarian bloom will have inositol and CoQ10, vitamin D. What am I missing? Very good, like a food-based prenatal, PRP, plasma, platelet-rich plasma, and then do very, very low, 100 Gonalev, 75 Aminopure, 150 Gonalev, 10 to 20 of ACG throughout the stimulation, and then definitely dual trigger with 10,000 units of ACG and Lupron. What do you recommend for low morphology in men? Is there anything we can do to get a better sperm quality? IVF is the way to go for sperm issues, especially with morphology and low count, depending, because usually morphology will come with low count. I was doing a little pilot study on PRP in testicles, and we've had some interesting results, some positive results. Definitely diet. Keto is king. I know it's really hard. You can make it your own. Keto means the percentages of the macronutrients. So I know that Dr. Kill's keto, it's, a lot of beef, but you can make it your own. You can do keto and not have any red meat at all if that's not something that you like. You don't need to do keto and for having had any meat. I mean, you could do keto just by measuring the micronutrients by doing eggs, or fish, or whichever way you want to do it. And then, like I said, we were doing a pilot study on testicular PRP. I mean, if you think about it, there's a lot of evidence of PRP being very good for low reserve in ovarian PRP, and the testicles are the man's ovaries, right? You want to be on glandular therapy. There's a few supplements that I really, really like. There's a company called Ancestral Supplements. They are organic, grass-fed, and they have a supplement called male optimization, and that's a good one to be on. Besides, your basic vitamin D, CoQ10, very good for motility. Minerals. Semen needs a lot of minerals. Okay. Hello, everybody that's joining me. Okay, so Miss Olayemi, follow up with her comment about, so I guess you had a very extensive retrieval, and then you had a fresh transfer day 3. And then did you develop symptoms? Because usually if you don't get pregnant, then it's not a big deal. The chances of hyperstimulation syndrome will not interfere with getting pregnant, okay? So the only thing is that if you did have a very extensive retrieval, then there's going to be a lot more inflammation in the pelvis, because in order to get the eggs, you have to puncture the ovaries, right? So if they have to pull out 20, 30 eggs, those ovaries are going to be inflamed. The pelvis is going to be inflamed. It's not really the best place to put an embryo. But if it works, the chances of the risk of the hyperstimulation syndrome is not going to interfere directly with the pregnancy. However, if you do get pregnant, then it's a problem, because then the ACG is going to start racing, going up, rising even higher, estrogen as well, and makes the hyperstimulation syndrome even worse. When I was a resident, we had to keep them in-house because then the pregnancy made it worse. So it was really hard to keep it together. Okay. How do I feel about transferring 2 embryos at one time? I always say one. I know that some of you will transfer two. It depends. So most women that want to transfer more than one is because they're older. And then you're older, you're not going to make a lot of embryos. Each embryo is a golden token. Okay. So it's not like you're playing in Dave and Buster's and just flipping the coins. Each embryo is the chance of a pregnancy. And after spending thousands of dollars in IVF and in medication, me as a woman, I would want to give each embryo the best chance of survival. And then when you're putting two to compete for the food and space of one. This is not a spontaneous twin pregnancy. And even on spontaneous twin pregnancies, they're high risk for miscarriage, preeclampsia, gestational diabetes, preterm labor. And after all the work that you put in, I'm sure you don't want to have a preterm labor baby that end up either in the NICU for a few months or, with permanent disability due to prematurity. So everybody talks about the successful twin babies from IVF, but nobody talks about the one that got miscarried at 16 weeks or the premature babies. All right. Ultimately, the rules of the game, just to finish that subject, ACRM, so the American Society of Reproductive Medicine, says 35 and over, you can put two. However, if you have normal genetic embryos, is one, no matter your age. That is the recommendation. Okay. Can Benadryl and Claritin help with recurrent miscarriages with an overactive immune system instead of prednisone? Yes, they don't work similarly at all. Benadryl and Claritin will decrease some of the histamine effect. So, and it'll dry things up. So there's any, fluid in the uterus related to inflammation. But they don't work exactly like the prednisone. But if you cannot tolerate the prednisone, it's better to be on an antihistamine that not be on anything at all. Are there any steroids safer than prednisone? Not really. I mean, prednisone compared to some of the other steroids is it's definitely more powerful than cortisol, which is your natural steroid, but it's definitely not as potent as some of the other injectable ones. So either you do it or you don't. You can definitely decrease the dose and go in a very low dose if that's an issue with recurrent miscarriages, or you can go into alternative medicine. I mean, you can definitely message me, and I have a bunch of supplements that we can work with that might help with the immune response. Okay, so yes, so Orayemi, yes, excessive water was drained on retrieval. So you did have a kind of signs of hyperstimulation. So I probably would have not transferred because the inflammation, it just was not going to be conducive to a successful transfer, in my opinion. And I would have given you a diuretic. In a natural FET cycle, when would I be having my transfer after my period? So in a natural FET cycle, you would be having, they will monitor you and figure out when you ovulated. Personally, I like to trigger, so I have better control of when to give you progesterone. And then for day 3 embryos, you would get 3 days of progesterone. And then day 5 embryo, you get, or a blast, you would get 5 days of progesterone from 36 hours after trigger. Okay. And then Miss Spilberry. So I'm sorry that that you did not get a reply. You're welcome to message me through Messenger, and I'll look at your chart and kind of discuss with you. Luckily, most hyperstimulation syndromes are mild to moderate, and they don't really pose a true threat to the patient. Even with water in the belly, like most patients do fine, and it's just conservative, kind of supportive and conservative management. But again, you can definitely message me with your name, date of birth, and phone number, and I'll take a look at your chart tomorrow, and we can definitely chat. How to make eggs grow beside keto. ACG low doesn't have not helped. Gonal max, no. If you have low reserve, traditionally they would use very, very high doses of injections, so gonadotrophin, so FSH, and Menopur, so LH, FSH. And they realized that with low reserve, in most cases, that's not the best way to do it. Okay, it's kind of they fry the eggs. So we're going in the opposite direction and doing mini IVF and low dose. Now, just remember, we're all very unique. There are exceptions. So there are people that do better on the high dose. And this process of fertility, or anything really, it's therapeutic and diagnostic at the same time. So it's kind of, we are learning about you as we go through this journey with you. There are things that we can do, Victoria, to try to help your eggs. It's a combination of things, okay? It's age, general health, and how much is your AMH. If it's really, really low, we can try. I mean, miracles happen every day. I just had a patient today, and her AMH doubled with the intervention, but she was 32. So, age does play a factor. It's not all, but it does play a factor. All right. There's human growth hormone that we can use. Some people do better on the low dose ACG, but some people do better on the Menopur. And Menopur is, for me, a better choice. It's in a lot of patients, especially in the older population, because of the way it's prepared. Okay. And it's funny because I was discussing with the Atlanta team today some of especially the immune protocols, and went to kind of customize the different protocols and when. So again, just message me through Messenger so we can look at your particular scenario. How long do you have to wait to do a transfer after hysteroscopy? Next month. You don't really have to wait. Can I transfer 4 embryos at once? No, absolutely not. Especially at 26. I was doing transfers in Syracuse last Monday, and it's the first time that I've seen somebody transfer 4 embryos, but 2 were very poor grading quality, and she was 43. And even that, Dr. Keels talked to her, and Dr. Corley, and she was adamant about just putting all those 4 embryos in. But at 26, Okay. Had an embryo transfer. This is a good one, Tisha. Had an embryo transfer 6 days ago. Had blood work done yesterday, but my E2 dropped a little. A little, it's okay. That's normal. Your hormones fluctuate. Progesterone, all of them, they fluctuate. And it is normal for the E2 to drop as the estrogen that was being produced by your eggs start going down. As long as it keeps at a certain level and above, no worries. that's why we kind of monitor you very closely. Okay. Who make the decision if I'm able to transfer two with a history of 2 miscarriages and 2 failed IVF and early clinic? I'm actually at your office. It's a joint. We are here to be kind of your life coach through this process. It's a joint decision. Whether you transfer two, I will tell you my opinion, just like I'm pretty vocal about how I think, for good and for bad. And then ultimately, if within medical reason, you make the final decision. Okay. If we choose to go to Atlanta for IUI, would you be the one? Yes. Yep. We are expanding. We are looking for another fertility doctor for the Atlanta office. But at the moment, I am it. Dr. V, I have adenomyosis and 1 endometrioma. Anything I can do before IVF? You could do laparoscopy and clear that endometrioma. We can do PRP and endoscratch on the uterus, as well as uterine priming with supplements to try to improve the lining and potentially shrink the adenomyosis. We can do, depending on how much time you have, we could do enzyme therapy as well. Just message me and I'll give you a protocol. Okay. And yes, so I know that everybody is asking about what's happening with Atlanta. We are working on it. I know that we've been talking about March through May to start doing transfers. I don't think March is going to happen. It'll require a miracle. But we are working again on expanding staff, getting an experienced embryologist, getting another fertility doctor for the office. We just hired a new RN. She's going through training. We just hired a new NP. She's going through training. We hired another medical assistant. She's going to training. So as we expand, we have to allow the new staff members to adapt and get trained enough and comfortable enough so we can serve you better. So that's going to take a few kind of growing pains to get to a point that we can do that. All right. We're also going through the kinks of construction and permits and all of that good stuff. All right. But we are definitely working on it. It's coming. Mucinex for inflammation. Any thoughts? Yes. I use Mucinex, not so much for inflammation, but sometimes people tend to have liquid in their fluid in their lining, or, then I will give Mucinex with antihistamines. Nurses don't recommend I use egg donor because they say my ultrasound shows 20 left, which is high for my age. I would have to look at your chart. 31 years of age with PCOS, you should probably use your own, and we should tweak your overall health and your protocol to optimize the outcome. What determines if one should use day 3 versus day 5 embryos for transfer? That's very controversial. Historically, we wanted blastocysts, so day 5 and beyond, because that's what's physiologic. That's what happens in nature. It takes 5 to 7 days for that embryo to make it to the uterus. But on older ladies, day 3s tend to do better. Also, if you're doing a fresh and you're traveling, that's less days that you have to stay around. And it looks like they do almost as good. Day 3s and day 5, they do almost as good. So it is kind of controversial. Do you allow transfer of 4 embryos at once? It depends on your age. Like I was saying, we discourage transferring more than 1 or 2 if you're 35 and over, or you've had any complications that fail. We would be a lot more relaxed about putting 2 in. If you're less than 35 and good looking embryos, we really encourage you to do 1. We've had certain situations where 2 is okay. In all the years I've been with CNY, I've only transferred 4 embryos in a lady. She was 43 with 2 poor graded embryos. And that was after speaking to 3 physicians. Okay. More is not better. Trust me. We just lost our baby at 5.5 weeks. I'm sorry to hear that. After your fresh transfer, is there any way to know why, or would you change protocol for next to avoid happening again? So we can definitely look and see how can we optimize your transfer. It is a great sign that you did get pregnant. We just have to figure out how to keep you pregnant. A lot of ladies have the unknown of why they don't get pregnant. In your case, you got pregnant on a fresh. So that, that does have a silver lining if it's not, even if it's not exactly the outcome that we're seeking. We would have to kind of, look and see what else can we do to keep you pregnant. Okay. We're doing an ERA with a natural cycle. We're using a trigger. Of course, I mean, an ERA gives you information. It's not a cheap procedure. It's between the medications, the pathology, so the lab, and the procedure is about $2,000. And you want to do it just exactly the same way as you would do your transfer. So yes, I see the benefit, especially if you had several failed transfers. If swelling feet and ankles is a side effect for prednisone, yep, it can be. Yep, it can be. So you might want to tweak the dose. Prednisone on some people can be pretty lethal. It makes you blow up and gain weight, or get you jittery or angry. Everybody's very different. Headaches. Okay. All right. So I see you guys have a lot of questions for me tonight. Okay. All right. All right, everybody. So always a pleasure to be with you on Tuesday evenings. And I know that I did not go through all of your questions. You're welcome to message me. I do have a Facebook page for the patients. I try to answer within a day or 2 max. And I will, try to, if it's something complex, then I'll make sure that you get on the schedule to speak to me. And we're here to serve and be part of your journey. Okay. We celebrate your successes, and we definitely get really sad when, there's the miscarriages and the not so great outcomes. However, like I was telling one of my patients today, as long as there's life, there's hope. And this is a marathon, it's not a sprint race. So you have to keep your eyes on the prize and always see things through, positive light. All right. So good night, everyone. And I will talk to you next week or through the week. All right. Bye-bye.